Why do they have the baby? Why do they have the baby in front like this? Right after you.
You guys, if anyone's interested, thanks for your patience as I get this going, but if anyone's interested, I brought a list of the exercises from last week. That one's really long, but if you guys like want a printed copy, right here. Okay, I'm ready.
Ready?
Yeah, I'm ready.
All right, I guess we'll get started. Do you guys have any questions from last week? Any thoughts? Okay. So we'll get started. So today we're going to talk a whole bunch about labor and delivery. So I love this. We have a secret in our culture, and it's not that birth is painful, it's that women are strong. And I think that's so true. We had one gal in class, and I think she had 4 babies. And she said, I just feel like such a badass every time I deliver a baby. And that was her reason for not wanting an epidural with the next one, was just because she felt like such a badass every time she had a baby. And whether you get an epidural or not, or deliver via C-section or vaginal delivery, I think, birth is an empowering feeling, just that you brought a life into the world. So we'll talk a little bit about the stages of labor. So the first stage is the process of dilation from 0 to 10 centimeters, right? So we talked about this a little bit last time. And so I think when people talk about like, oh, I was in labor for 30 hours, or I was in labor for 5 hours or whatever, the part that they're typically referring to is this stage 1 of labor, that process of getting from 0 to 10 centimeters. Stage 2 is the delivery of the baby. Stage 3 is the delivery of the placenta, and then stage 4 is that transition to extrauterine life and bonding for mom and baby. So stage 1, the dilation itself is actually further broke down. So it's from that first contraction until you're fully dilated. So that early stage labor is 0 to 6 centimeters, and they, like in the last couple of years, changed the definition. It used to only be 0 to 4 centimeters. So sometimes things that you read might say 4 centimeters. But Dr. Gallagher always tells his patients that early stage, that latent phase of labor can take 2 hours, 2 days, or 2 weeks. So if you come in and you're 1 centimeter dilated, and you live right here in town, it's like we might send you home, because that process of getting through those first few centimeters can take a really long time. Now, I can tell you in a bigger hospital, they typically will not admit you until you're 6 centimeters. So if you're like 3 centimeters, they might say, yeah, we'll keep you in triage and you can walk the hall, but you're not getting a bed until you're 6 centimeters. In Lakeview, we're quite a bit more relaxed about that. And it also depends on where you live and what the weather's doing, right? Like if you live a block down the street and it's 80 degrees, then you could stroll down the sidewalk. That's one thing. But if you live, in Eagleville, California, and it's a blizzard outside, we're probably not going to send you home. Sometimes even for the people that do live out of town, if you come in and you're 1 centimeter, we might suggest that maybe you get a motel for the night. Like, don't go all the way home, but we don't necessarily need to admit you. But like I say, once your labor starts progressing and you get through that early stage of labor, it typically goes a lot faster. So then active stage, 6 to 8 centimeters. Early stage, I feel like is like, you're kind of excited, you're in labor, maybe your water broke, like it's not so intense. Maybe you can take a nap or a walk or whatever. By active stage, like you're really having to focus and breathe through your contractions and concentrate. And then by transition, so that is 8 to 10 centimeters, and that's like the most intense part of labor, but typically the shortest. Transition is, you know, when you yell at your husband, when you scream at people, like, for whispering and they're not even talking. That's when most women say, like, I can't do this anymore, get this baby out of me. You know, and when there's no reasoning with them, like, but it typically lasts only a short period of time.
And that's when the mama bear hormones like really kick
Thankfully.
in. So this is like when adrenaline and norepinephrine, epinephrine and norepinephrine hit your system hard, and it gets you through this last stage of like the last and hardest stage of labor and through pushing. So like your hormonal cascade that's happening during labor is going to also help you get through this. So like, I mean, like those are the same hormones that help like moms lift cars off their children. Like, so like you can do literally anything with the amount of hormones that are coursing through you. So have faith in your body for that, and really encouraging that too. Like that is when like maybe you don't want to be touched more, and that's okay. Or maybe you need stronger pressure because that is like what your body is kicking back at you. So really listen to your body as you're going through that also.
And I feel like early stage, you're kind of like trying things out, like, oh, okay, like it feels good to take a walk, it feels good to sit in the bathtub, it feels good to do this or that. And you're kind of like playing with some different ideas, because then once you get to active stage labor, like you want to know what is working for you and what's not working. But then it kind of seems like transition is when you have to change it up again, or you might need to change it up again, you know, like maybe counter pressure on your back and your hips was really great, and then all of a sudden in transition, that doesn't work anymore. And so like, I think for partners to just be really like flexible and like, you know, oh, that was working and now it's not working, maybe we'll try something different. Like, and then for moms to try to be open-minded. You know, like I know as a nurse, like I'll try to get a lot of women in the bathtub if they're trying to go natural. And a lot of times they're like, nope, I'm not doing that. You know, and if I can finally talk them into it, then maybe it will work really well. You know, sometimes it doesn't, but a lot of times it does work really well. And maybe if it's something that you thought you wouldn't like, maybe it's worth trying just because it's, I mean, I guess only one of, you know, Terry, you've had a baby before, but nobody else has. And one delivery to the next can be different, you know, like one of my good friends, her first delivery, I was like, well, let's get you in the bathtub. And so as soon as I got her in the bathtub, she was like, nope, this isn't going to work. And she's like crawling out of the bathtub on the bathroom floor. You know, like just terrible. She was throwing up. She had diarrhea all over the bathroom floor. She's just like, this is horrible. Like, I can't imagine anything worse. And then the second baby, I was like, let's try the bathtub. And she just kind of looked at me like, don't you remember how traumatizing that was the last time? You know, but like with that baby, it was great. So it's just, you know, every labor is different.
I think something really important to note is that there will be poop. Like, just be ready for it. Every partner mostly. And pregnant women too. We had a pregnant lady not too long ago who was really concerned about it. What was the question? We'll hand you a trash can. We'll hand you a trash basket. And probably a rag to clean up your own vomit. Yeah. I mean, we will park you in the corner.
Actually, the best is that the poor husband, like, as she's puking and pooping on the bathroom floor, he comes in and, like, cracks the bathroom door open and is like, hey, honey, I'm going to fill out the lunch menu for you. Like, what do you think you want to eat for lunch? And she's just like, get out of here. I think chili was one of the options. She was just like, enough. Oh. Okay, so now we're going to watch a birth video. Do you think we can handle this?
I'm excited.
Oh, I can try.
You think I got sweaty palms? Yeah. Don't eat. They're gonna be walking through the park.
You should do the same thing.
No.
From what you go out of the corner.
We should have.
Yeah, no problem.
She's like, well, we're not even getting we're just, I'm getting ready to. Nothing's going on. You're very true. He's like,
Hi, I'm Brandy. I'm 37 weeks. I'm Shane. Brandy's husband. Oh, I can't wait. I can't wait for her to come back again. You know, like, I'm ready to be done with it, you know, having a baby. Having a nice birth really works. Being women in this country, they birth with thousands of
Everybody still upright?
I just kept thinking about that popsicle. Thing to think about. Can they get that delivered?
For folks online, thanks for your patience. I didn't think the sound was going to come through very well, so thanks for just reading it.
So that's a great thing to like think about. Like we have a little freezer. So plenty of women do bring in popsicles or, you know, whatever the heck they want to bring in.
If I could have a fudgesicle.
You can have whatever you want. Well,
Mid-pushing.
Not if you have an epidural.
Hold it. Clearly.
If you
It could be
go
a juice
natural,
popsicle,
you
right?
can be slurping down a fudgesicle. But yeah,
you could have a red popsicle.
Juice popsicles, that's fine.
The firecracker one.
Yeah,
Just clear the food.
clear. Yeah. Yeah. So bring in a box of popsicles if that's what you want.
But again, right, we talked about like during labor, you want to have like things that are going to be nutritious too. So like during pushing, right, like you're near the end, that'll probably be fine. Like that little bit of glucose will probably be good. But, you know, if it's early labor and you're starting to like put those popsicles back, like I would probably like slow down on that and think more like granola bars and, you know, if you can like, or trail mix or something like this, a little more nutrient dense to get you through potentially 20 hours. I mean, I was actually just thinking, we've watched this video now
A lot of
half a
times.
dozen times. And every time I see something new and I'm like, man, that doula was rocking it. Like she was
I know.
the whole
I think
time.
that too. Yeah.
Yeah. But Dad had to take a break, so. Yeah.
So I always think it's, like, especially if you haven't watched, how many of you guys have seen a birth? A real birth? Yeah?
I've only seen one, but I've just seen one.
Okay.
I'm just excited for this one.
I know. I mean, you've heard one, so that's pretty good.
Oh, yeah. Yours, yeah, for hers. Probably down for yours.
I would say yes.
I really like this particular birth video because I think it demonstrates a lot of different things. Like number one, it shows all the, she was like constantly moving, like constantly in different positions. And I mean, really, you know, like everyone talks about wanting to have like a quick labor, but truth be told, you want like a medium-sized labor, right? Like you don't want so fast that it just blows everything out the bottom. I mean, the baby's out, but then like you got to recover, right? And you don't want that 65-hour labor. So you want something that's like nice, low and slow where you've kind of got this constant stretch to your tissues, right? So, you know, a girlfriend of mine, she had a labor that took 3 hours on her first vaginal delivery and ended up with 21 stitches, for example. And she's fine, right? I mean, like she recovered just fine. Like that's what pelvic floor PTs are for, is we fix you after stuff like that. But
That's why she's friends with Anna.
that's why we're friends. Yeah. There was lots of text messaging going on. But you know, you like kind of be like, if you can shoot that like 18 to 26 hours, I mean, that's kind of ideal for like tissue and muscle and joint stretch. Because there's a lot that has to happen. And I made some notes to myself that I remember too. Do you have anything you add before I go off?
I was just gonna say, I love watching that, like the birth partner through the video, because I think he just like gives you ideas. Like if you've never seen a delivery or you don't know what to expect or whatever, he does give you lots of ideas of like things that you could be doing. Because I think for birth partners, sometimes you're just like scared or intimidated with the situation, and you're just like, I don't know what I can do to help you. Like I can see that you're in pain and I don't know what to do to help. So I'm going to sit over in the corner and, you know, and then we perceive that as you not caring, and then we're mad at you. So sometimes I think just to have some ideas of like what you could do to help out is helpful.
And you'll walk away from class today with that too. Like partners, like I just realized this is not the front and back that I normally hand out, but I'll print some more before you guys leave today. But it's literally like, what do I do next? And it's like, well, you start here, and if that doesn't work, then you go to this one. And if that doesn't work, then you go to this one. And if that doesn't work, then you go to this one. And then once you get all the way down through them, you're like, well, those aren't working, so we're going to start back at the top. Like this is like, what do I try next? I would totally recommend it, especially if this is your first time through, especially if like mom doesn't know what she wants or what she needs, these are what you can suggest to help out. So I would totally suggest just packing it in the bag or just have it in your back pocket. And then, you know, if you guys are in labor when I'm at work too, I try to like poke my head in and can bring you another copy of this. So yeah, like between the video, in your booklets that we gave you too, you actually have access to all of these videos. So you can watch other, like there's a pushing video.
Yeah.
There's like a laboring video. So you guys can like watch those videos and see people do it as well, but we'll go through these too. So I think, you know, like some of the partners we've talked to, I think if they're not nauseous and about to puke or faint, I think the struggle that they have is really knowing how to support. So this can be a good resource, and just educating yourself and figuring out ways to do that. One thing that I think is really cool in the advent of COVID is, especially when so many hospitals were like not allowing anyone into the delivery room besides the mom, and then like barely her sometimes. So doulas went online. So we don't have doulas here in Lakeview, so most people just bring, you know, untrained support people, which is fine. But there is a whole list of virtual doulas. So if you are interested in using a doula, and like this can be an awesome thing for partners too, because the doula can be like, okay, Larry, I want you to set her up like this, then put your hands here, and then, you know, give pressure there. Maddie, do you need a popsicle? Like, is it time for some water? Do we need to change positions? So they can be, give you some of that hands-off support, but help you support partners or as a laboring mom, like give you ideas of what to do next. So that is a really cool thing. And if you're interested, make sure I get your email before the end of class, and then I'll hook you up with the follow-up email to the online class, because I'm going to include the link to the list, like the national list of virtual doulas.
One of the things that I think is like nice and unique about Lake District Hospital is that once you're in labor, we have a 1-to-1 nursing ratio. So there's just one nurse assigned to a laboring patient, as opposed to some bigger hospitals. You might have 2 or 3 patients that you're laboring. So you're like, you know, bebopping here and then there and then there. Whereas like if I have somebody that, you know, wants to go natural and wants to try and, you know, do it while they're moving around as much as they can, like I'll spend my entire day in the room with them, you know, just like helping them through labor. So, you know, now of course, if I have somebody that, you know, wants an epidural and wants to have a little bit more privacy, like sure, I'm in the room plenty, but, you know, I can try to pull back a little bit, but it's just kind of dependent on what you want. And just like, I think just vocalizing that to your nurse, like, you know, I really want to try and go natural, or I want to walk until I get an epidural. Like, can you help me with different positions? Just asking for that. Sometimes I think just makes the nurse more aware of like, oh, okay, they really, you know, like I can help them with suggestions, as opposed to, you know, sometimes I think we just assume that you know what you want, and maybe you really don't know what you want and you want help. So it's okay to ask for that.
Another cool thing, did you guys catch like at the very end when she was pushing and baby was crowning, how like they had her rolled off to her, like her shoulders rolled off to her side a little bit. So like even though she was in that dorsal lithotomy position, she likely had rolled just enough to free up her tailbone. So like when we were saying last week, like it doesn't have to be much to get off that tailbone if that is like the most effective pushing position for you, or if that's the position you wind up in. It doesn't take much to like free up that tailbone and give you some room. So I thought that was really cool. And the other thing, there were 2 vocalizations that she did that I really liked. So we talked last week about, you know, the breathing and how you take that big breath in and it relaxes your pelvic floor. And Julie, our speech therapist, will be upset with me for not remembering what it's called. But did you guys see her go? Did you guys see her do that? So that is a really effective technique to release your pelvic floor. So if you're finding yourself, even just during intense contractions, really great way to exhale, because it will cause a reflexive release of your pelvic floor. So that's a really amazing thing to do. And then the other thing she did, you know, is with pushing. So as a pelvic floor PT, I am strongly against all Valsalva, which is you take a deep breath in, hold your breath, and push as hard as you can. The reason I don't like that is because it closes your glottis and locks your pelvic floor. So you created this canister of your abdomen that has now locked itself in, and so you're trying to shove a watermelon out through concrete now, as opposed to getting an exhale with that push, and then that allows your pelvic floor to not be locked in quite as tight. So one of the things, so she did that like bilabial exhale, and then the other thing she did, like the doula was saying, like down your spine and out your bottom, and then it was like that low, like and then I think she came up towards the end of her push. Vocalizations, like those low vocalizations like that, are also really, really good for your pelvic floor. So if you start to get like pushing up here, that's not it's just not effective. Like you've lost your push now. But if you can get that low vocalization, that's going to really help you be much more effective at pushing. And unfortunately, first-time moms, and sometimes even second-time moms, are like terrible pushers. And so we'll coach you, but like I said, the coaching is generally like hold your breath, like push as hard as you can and count to 10. And again, like that's not as super effective as the pelvic floor, but it's also like something very easy for people to latch onto. So if you are struggling with pushing, don't feel like you're super effective. See if you can add those little pieces to it. But yeah, I mean, like we had a gal not that long ago who like she had an epidural and was super effective at pushing. So, you know, just wait till you try, like you don't have to be feeling everything to be super effective at pushing, but you know, those are just a couple of things from the pelvic floor perspective that I think can be really helpful.
You can kind of expect it when it gets time to push. So if you, like Annika was talking about the last time, you have that Ferguson's ejection reflex, which when I think of pushing and that urge to push, like people will say like, yeah, I'm having pressure. Yeah, I think I need to push. That to me is like nausea. Like, yeah, I don't feel good and I might throw up. That's the same as like, yeah, I have pressure and I think I need to push, as opposed to like when I'm just vomiting all over the carpet and I can't control it. That's when you actually have that like intense urge to push, that ejection reflex. Like no matter what anybody tells you, you cannot control it at all. And I think that's the difference between like that pressure and that urge to push versus like, I'm pushing this baby out right now. Do you remember what did you feel when you had Ren? Were you coached to push, or did you feel that urge to push?
I was induced, and I did have an epidural after they broke my water, and the nurse kept saying, like, you guys were talking about laboring down last week. And the nurse kept saying, like, I want you to labor down, I want you to labor down. And Zane and I were both like, we don't know what you're saying.
Right.
I don't know what you're saying. And so she's like, just wait, like, as long as you can, just try to relax. And you'll feel the difference. And then you let me know. So, like, I was getting stronger contractions. I was just waiting it out, and she was in the room with us. And finally, I was like, I'm ready to push. And she's like, okay, once, our resident is in doing C-section right now. Once she gets out, we'll have her come in, we can do some practice pushes, and we'll see where you are. And I was like, okay, you just say, like we're done. And then she was like, no, I'm ready. And she, once the resident came in, she's like, you guys call the doctor, right? Because she's like, she's ready, we're pushing.
Yeah.
Like, this is not practice. And they called him, and he rushed right out. But no, you can definitely feel it.
Yeah. So with my first one, I mean, I didn't have an epidural. I went natural. But I pushed for 4 hours, but I still never felt like that, like intense urge to push necessarily. The second one, I had an epidural, and he was having big deceleration. So my first two were vacuum babies. And so it was just like, you need to push him out right now. But there wasn't really an urge to push.
And then in the middle of this, I start teaching childbirth education with her and talking about the Ferguson ejection reflex, and Megan's like, no.
Never happened. And then I had the third one and was natural again. And that time, Teddy can attest to it. I mean, it was like life was fine. I mean, it wasn't great, but it was okay. I was in the bathtub. Annika had just come in to like chit chat. And then I had to get out of the bathtub, and it just hit me. And I was like, Dr. Gallagher broke my water the rest of the way. And it hit me so hard. And I was just like, I am, and he's like trying to coach me. And I've coached tons of women to push.
and he's like trying to control me, you know, and coach me on my pushing, and it's like absolutely not.
The freight
Like,
train that is
I am
not stopping.
doing this, you know, my body took complete control. Like that was me like vomiting all over the carpet. Like nobody's controlling this. And my body did it 1,000% on its own. I didn't do a thing. So it's so interesting to me how that, but I would say a large majority of our first time moms and then moms with epidurals don't get that super intense urge to push. And so it's like you can expect it, even if you have an epidural, that your doctor will probably turn it off once you're complete. And it will take a little while for it to wear off. But as it wears off, you're able to feel your contractions a little more, and so you're able to push more effectively.
And it's good to be prepared for that, because sometimes women are not, and it's a huge shock. They're like, no, I wanted to feel nothing.
Right.
No thing.
Right.
And then you can feel everything.
Yeah. But it is helpful to turn it off a little bit so you can at least, you know, because if you've never pushed out a baby, like it's really hard to know what to do if you don't feel something.
So they don't give you like a morphine button, but for your
Yeah, so sometimes, like, so it depends on your anesthesia provider. Some anesthesia providers do give you a button that you can push to redose yourself. Others don't. And Gabe doesn't. Andrew, honestly, I don't know about Andrew.
I saw one.
Hasn't been. Yeah. But I would say, like, just the continuous rate that's infusing through your epidural seems to hold most women. But once you get to the end, we turn it off. One of my friends was like, how long until this thing wears off? And Dr. Gallagher said, well, probably 30 minutes. And she goes, well, then you have 30 minutes to get this baby out. So off to. So that doesn't happen for most people. But, you know, so if you don't feel that super intense urge to push, but you're complete and you've labored down, we will coach you through pushing. So even as much as the physical therapists don't like it, typically what we are doing is having you kind of curl up around that baby, take a big deep breath, and you're pushing to the count of 10, another big deep breath, pushing to the count of 10, another big deep breath, pushing to the count of 10. So 3 pushes per contraction is typically what we're doing.
And that length of push isn't like necessarily, and the position isn't like the piece, it's the hold the breath. Yeah. So, I mean, even during that, if you have this like moment of clarity and you're like, oh, they said in my childbirth education class that I should while I'm pushing, then go ahead and do that. Like, that's totally fine. But if you're not effective, I mean, like that, like a Valsalva is extremely effective, right? Like you are going to push despite anything that's in the way, right? But it's definitely something to try. Like if you are getting like effective pushing happening, like you can start to add some of those vocalizations in. And even if it's something as little as and having just some release of air, that'll still maintain that same pressure with the Valsalva, but it won't lock in your pelvic floor.
And those releases of air and that noise, that's that really low, deep guttural noise, as opposed to just like everybody has a contraction where they're just like, I can't do it, I can't do it, I can't do it. You know, they're screaming and crying. And it's like, all right, we can all have one of those. Yeah. But then like, let's get it together on the next contraction. Yeah.
So partners, that's a great thing for you too. Like if you notice that especially if you don't want to be down near where the action's happening, you want to like stay up near her head. Like that is a great time to like help coach her on vocalizations. Like make sure that those are effective and not getting too breathy and high.
See, that's what I did, like, them right there, like, I didn't have to be breathing on my neck in my ear.
You can or you can't.
That's how people get knocked out.
Well, that's fine, right? That's totally fine. Like, they don't need it. They can be wherever you want them to be. They absolutely don't need to be here.
I was just thinking about.
Do you want them catching the baby? Does that make you feel better?
With what?
If they're down there catching the baby?
No.
Also no.
Not putting enough hands. At all. I'm worried about the jacuzzi. Is there enough room for both of them?
In the jacuzzi tub?
What if it's a beer belly?
I would put that maybe. They're not that.
I'm trying to think, like, if I have seen 2 people in the tub I can't attest for how cozy it
What
was.
if your husband poops in a tub while you're in a heat run down?
Well, they're gonna blame it on you.
100%.
What's that loud baby?
People always ask, can I deliver in the tub? And we strongly prefer that you do not deliver in the tub. We'll be getting you out of there as quickly as we can.
Sometimes things happen. You won't get in trouble. Sometimes. Yeah.
Right.
A friend of mine from PT school, his wife just delivered in the parking garage. They were in like a big hospital setting, and he couldn't decide where to park, and that's why she delivered in the parking garage.
Oh, gosh.
Labial trill.
Labial trill. Thank you. I'm gonna write that down.
That is the.
Okay, so, oh gosh, we're gonna run out of time. I know it for sure. Okay, so we're gonna move right on to this. So, I'm gonna give each of you guys a set of these cards.
So I just want you to kind of like map out what your ideal birth plan would be.
And for those who are online with us, if you filled out the birth plan survey, that's what we're doing right now. I'm gonna print one. Okay. Tell Gabe I'm resending it to him. Or do you want me to text it to you and then you can text it to Gabe? That'd probably be faster. Whatever. No, that's not gonna work. Okay. Tell him I'm resending it to him.
Are you guys partnered up?
We're,
Okay.
Fair enough.
We're talking about our birth plan,
Okay.
so.
Are you guys all, you got it all lined out?
Yeah.
Okay, so we'll go around the room. You guys just share what your birth plan is. Do you guys want to start?
I didn't really have a birth plan last time.
Okay.
Because I got confused and I kind of went with whatever happened. So I put things like here that I know that I like want, and things over here that I'm not sure.
Okay.
So we don't know the gender, so not but I would like to walk.
Okay.
And have like no forceps vacuum, shorter labor, try for vaginal. And that's basically all the things I know. I haven't set it up as a this time.
Did you have one last time?
I did.
Okay.
Like last time she was doing fine and then they broke her water
Uh-huh.
and then
They had
10 minutes later she was like, go get a doctor.
the Pitocin turned up pretty high.
Yeah.
And, so they started me on Pitocin at like 7 a.m. And at 10:30, they were like, oh, we're not really progressing much, let's break your water. Because I was a week late and Ren was measuring big.
Mm-hmm.
And so like, we can do through the things
Right.
happen. And they're like, we're not progressing much, let's break your water, and then we can decide. And she's like, usually we want the epidural before we break your water. And I was like, oh, just do it. Let's see. And so she did, and then like 30 minutes later, I was like, I'm gonna want the epidural if this is gonna get like more intense.
Yeah.
And then, so I got the epidural, and they're like, we need to turn Pitocin down, this is too much.
Oh.
So, I think, I don't know if my Pitocin was turned up too high for then, like, after they broke my water.
Yeah.
Because then it kicked in, like, really hard and fast. So I only pushed for 20 minutes.
Oh, that's not, and how big was she?
Almost 9 pounds. So 8, 15, 5.
About half ounce.
Just 9 pounds.
Yeah.
Yeah, it wouldn't have fallen from it.
If we wouldn't have sucked her out, then she would have been 9 pounds. Oh my goodness, she's 9 pounds.
Yeah. Okay. What about you guys?
Definitely want to walk the active as much as I can. Try natural as possible. Sterile, vaginal, that's the way it goes. Of course, through vacuum, preferably. She said it's a boy, no, they don't know. And that's it. I'm not much of a person like. Pretty similar. Mine's boy too. Vaginal delivery. I put long labor, but more like a medium labor. You don't want to have it too short. Because, I put no forceps vacuum, wishful thinking. No episiotomy.
I'm gonna take this as a challenge accepted.
No epidural. And I put walk during labor as much as possible. So plan.
Good plan, Ted.
Thanks.
Courtney, what about you?
I don't actually have a birth plan. I just kind of want things to go as naturally as possible. I'm on edge about the epidural, whether it won't work or not. The only thing I'm on edge is, but other than that, just being active and moving. I would hope for, things, but.
So I think, okay, so Gabe is our CRNA, and so he just logged in. So he's gonna talk to us about epidurals, and then we'll resume this discussion. But I think that, like, when I had my first and my second, I just felt like I went into it like so hell bent, like I'm not getting an epidural, like come hell or high water, I'm not doing it. And then 36 hours into my second induction, I was still not progressing. And so then it was like, well, I guess I'm going to have to get an epidural. And so I feel like my mindset really shifted. And then an epidural is really just a tool to achieve a vaginal delivery. And so sometimes, even if that's not what you want, if the alternative is like get an epidural or have a C-section because you're not progressing, like sometimes I think we view an epidural as like you weren't tough enough or you gave up or you couldn't do it. But really, I think an epidural is a tool to have a vaginal delivery. So, I encourage you to keep like an open mind about it.
Absolutely. Gabe, can you hear us?
Hi, yeah.
All right.
I just gave you a nice little intro on epidural, so the floor is yours.
I just picked up when you were breaking down and needing yours, so that's where I just cut in there. So I'm always kind of off the cuff when I give these talks. So if anybody has any questions that come up along the way, definitely feel free to just pipe up and ask. I'll just kind of talk kind of briefly about what happens before the epidural, and then what happens, when we do the epidural, what happens after the epidural's in, what the risks are, and what it means if you have to go to C-section, I guess. Not that anybody wants that, but it happens occasionally. So whether you're planning on getting an epidural or not, often if I am told there's somebody in labor in the OB unit, if I get a chance, I'll often just swing over and go through some information with you. Not because I have any, desire to push you into an epidural or not. It's just, sometimes even if you don't want an epidural, things change down the line, just like what Megan was saying. And likely in those cases, if things change down the line, it's not usually because it's a pleasant experience, if you know what I mean. And it's hard to talk to people, and it's hard to get things done quick enough in those kind of cases. So I always, just for full disclosure, tell everybody, hey, I'm on salary. I don't make a penny more whether you get one or don't get one. So for me, that's sort of freeing in that I can just tell you what I think, give you an opinion, and I don't feel particularly biased. I just want you to have the birth that you have, sort of planned. So that's sort of just like the initial caveat. If I do come in, it's just to gather information, just to get the talking done when it's easy and the pain's not bad, and and people process information much better when they're not hurting. So typically I just come in, we'll talk, I get some basic health history if you're allergic to anything, if you've had previous procedures, if you've had previous epidurals, so on and so forth. And then talk about the epidural and risks, and then there's a consent form. And once in a while, I'll even have people, somebody in labor, even if they're not planning on getting an epidural, sign all the paperwork just so it's on file. And then if I get called in and I have to drive in from home at 2 a.m, all that's on file. All we got to do is just get the epidural in you and get you comfy as quick as we can. So that's kind of the first point. So I guess the next point would be kind of what is an epidural? So basically what an epidural is a very tiny, I don't know if have you passed around like an epidural catheter, Megan?
No, I don't know what I did with it. I lost it.
Okay. So it's just a little hollow plastic tube. It's real flexible. And it's just an empty tube that gives us a means to put numbing medicine around your spinal cord, essentially. It's the same kind of medicine the dentist uses on your gums when you go to the dentist. It just goes in your back. It's called an epidural. I don't know if anybody's had anatomy or anything, but there's a sac, I guess you'd say, that contains the brain and the spinal cord. And inside that sac, there's spinal fluid. I'm sure everybody has some concept that there's spinal fluid. And that sac is called the dura. So when we put in an epidural, we take this hollow tube and we use a needle to get into place, and we put this hollow tube just outside the dura. And then we put numbing medicine there, and then the medicine's able to soak in and numb the nerves that, if you have information coming from, your pelvis or your legs or your belly button or whatever, it travels through nerves that go to your spinal cord and then go up to your brain. Well, at the point where they're kind of coming into your spinal cord, we put a catheter there, put a bunch of numbing medicine there, and then the signals get blocked right there. So if it's a pain signal, it doesn't make it to your brain, makes it to where you're unaware that you're having that pain. So it's sort of a brief rundown of what an epidural is. As far as, if it comes time to put an epidural in, we typically sit you up hang your legs off the side of the bed, kind of curl your back out. The way we position you, we just show you how we want you to position, and it just makes our space, our access to the epidural space a little better. So actually positioning in, like, if we say, hey, sit this way or that way, that's actually pretty important just in how easy or difficult it is to get the epidural in place. So basically we sit you up, we swing your legs off the side of the bed. I'll clean your back up with some antiseptic solution of some sort, put a sterile drape on there. We numb you up, a little bit of numbing medicine on the skin. It's a little poke and burn. It's about 10 seconds worth of poke and burn. And it's usually just pressure sensations after that. A lot of people say it's not as bad as getting an IV placed to have an epidural. So we get the needle where we need to go. We put the little catheter in there. The needle comes out, and all that's left is this little flimsy catheter that we're able to hook up to an infusion pump, and then we just pump numbing medicine into your back and keep you comfy until you deliver. I think that's kind of the gist of placement. Risks with the epidural. Kind of the main thing, there's about 1% chance of headache after epidural placement. The kind of headache that we worry about is the kind of headache that's bad when you stand upright or sit upright. It tends to get a lot better if you lay flat. It's called a spinal headache. If you get a headache like that, usually we pick up on it pretty quick. It's other things that are associated with it. Location is sort of in the front of your head and sort of back here. A lot of times there's photophobia, meaning you're sensitive to light, so dark room helps. If you get a headache like that, sometimes we're able to do conservative treatments. One of them, strangely enough, is caffeine, or once in a while, I don't know, I've been here coming up on 5 years, I guess, and I think I've done 1 or 2 blood patches since I've been here. So that's the other way to sort of treat it, and it's really effective if we have to do that. Other risks, anytime we put a medicine in the body, there's a risk for changes in vital signs. There's always a risk to react to any medicine we give you. When we put them in, we're putting this hollow little flimsy catheter into an empty space, and we put medicine in there, and we just kind of hope the medicine spreads where it's supposed to spread. And so it's not terribly uncommon with an epidural to have one leg that's more numb than another or something like that. If we have a situation like that, we will do what we can to make the epidural work perfect. Once in a great while, we'll actually pull one out and replace it if we have to, if we just can't seem to get it to work as well as we want it to. Let's see. When we put them in and we put the medicine in there, it's not that uncommon to have the blood pressure come down a little bit when we start dosing the medicine, partly because you're not hurting anymore, and your blood pressure goes up when you are in pain, and partly because your blood vessels dilate when we put numbing medicine around your spinal cord, and so we'll often give you a big bunch of fluid and kind of fill up your tank before we do the epidural, just to kind of prevent that. And that's generally very treatable as well. Let's see. I think that's the big points on the risks and benefits. Benefits, with the benefits, if you're getting a lot of opioids and you don't have an epidural, those opioids are in your, I don't think we're doing that as much now, are we, Megan?
No.
No, okay. I used to give a fair bit of fentanyl and stuff.
for laboring patients, and
Yeah.
that goes directly into your bloodstream, and baby will see a little bit more of the medicine when it goes into your bloodstream, as compared to what you get IV. Typically what you get in your epidural is about a tenth of what IV doses are. So you know, baby tends to come out less floppy than if you're getting a lot of IV narcotics. Although I think, you know, the general trend nowadays is away from lots of narcotics. Let's see.
Talk briefly
Go ahead.
the transition section.
Say again.
Did you hear that?
You cut out, Megan. Sorry.
Can you talk briefly about like the transition to C-section? Like if you had an epidural and then you have to go to
Yeah, so that'd be the next, kind of the next point. So often we'll put in an epidural when you're in labor, and you know, we're not sure which, you know, if you're going to have a standard vaginal delivery, or you know, once in a while something comes up, baby's not tolerating labor, maybe baby's heart rate's going down in a way that we don't like to see. And so in certain cases, the doctor, or you're just not progressing to the point where we think it's going to happen vaginally. So if we have that kind of situation, then you know, the decision will be made to go to C-section. What the epidural allows us to do, if we have to go to C-section, it just gives us a conduit to give the medicine, and we'll try to get you numb. Typically when you're in labor, we try and get you numb from about the belly button down. If we're going to C-section, we typically give a stronger medicine that's going to make you more profoundly numb. And we're going to give a bigger volume of that stronger medication. And we're trying to get you numb from about the nipple line down. And that helps so that we can do the C-section just on the epidural. So you can be awake when baby's born generally, and still can participate in the birth experience. The alternative to that, if you didn't have an epidural, you know, and you go back there, if we didn't have time to put a spinal in, then the backup alternative is going all the way to sleep, and that's something we generally try to avoid with pregnant women, just for safety reasons. It tends to be a lot safer to do the C-section with spinal or epidural medicine rather than with where we drift you all the way to sleep. Does that answer that at all, Megan? I'm not sure if I addressed that question very well there.
Yeah, I think that's good.
Gabe,
Mm-hmm.
when is it too late to get an epidural?
You know, I some people are more of a stickler for this than I am. I try to say it's not really ever too late unless baby's like crowning coming out. I guess I would say if you're so far along that you can't get in a position, either sitting up or laying on a side without baby's heart rate going down, you know, where it would actually, the process of putting the epidural in would, you know, put baby at risk in one way or another. That's where I would say it's too late. But as far as centimeters go, I've put epidurals in patients that are 0 centimeters. I've put epidurals in patients that are complete. You know, so as far as that goes, I'm not as concerned about that. And typically, if it's really far along, if you have, you know, come in and thought that you didn't want an epidural, and you've made it to say 9 centimeters or something, and now, you know, things are getting very real, you know, hurting real bad. Occasionally I'll get called in on those, and I'll just instead of putting the catheter in that we can redose, I'll just put a needle in directly into the spinal fluid, give a little dose of medicine that's good for a couple hours, pull that out. You don't really have the catheter in place, but you got a couple hours to get the job done in that kind of situation. So I guess what I'm saying is, for me, if there's any chance I can get you pain relief, I'll do my best to do it, as long as we can do so safely. And there's not really, like I say, a standard answer for when it's too late, other than, you know, if baby's coming out, or, you know, it's just not safe heart rate wise or something.
What are the
Other questions?
You were very explanatory, Gabe. That was wonderful.
Okay. Does any of the moms have questions at all?
Yeah, I think we're good.
Okay. We'll see you guys when the time comes to have a birthday.
All right. Thank you, Gabe.
All right. Bye.
Okay, so you were telling us, Courtney, maybe an epidural, maybe not.
That's the only thing.
Did that change, like, how you feel?
Well, it's good to know that you do have like time. Because I'm like, I don't want to come in until I'm like further.
I think, like, I don't know if Hollywood does this to us or what, but I feel like there's just like this misnomer out there that, like, once you're 7 centimeters, that ship has sailed and you're not getting an epidural. And honestly, like, there's a lot of women that are like probably in active labor, but they're just like, oh my God, I can't do this anymore. Like, I need the epidural. And we set them up at the side of the bed. We do the epidural. And as soon as they get that epidural and as soon as they relax, you know, then they're like, oh, I got to push. You know what I mean? Like, that's what happens, because, like, as you know, they're like, they probably were in active labor, but as soon as their body relaxes, whoosh, they're complete and baby is right there. So that happens all the time. And like I say, I don't think we should view an epidural as like a failure. It's just a tool to have a vaginal delivery.
I'm just worried, like, recovery-wise, it seems like a lot of moms that I've talked to have been like, their recovery was so much smoother and faster and better without the epidural.
So I
feel bad with, like, you know.
I would say, honestly, I would say both Andrew and Gabe, so we have these 2 CRNAs, and they do like 3 weeks on, 3 weeks off. Is that what they're doing? And they are both wonderful. And honestly, of all the women that I've labored and then myself, I can't say that there's a difference in recovering after an epidural versus not. So, like, after an epidural, like, maybe it would take you a little bit longer to get your legs under you, but if we turned off the epidural 30 minutes before you start pushing, like, it's one thing if your epidural is full blown and then all of a sudden you're like, I have to push, and you push out a baby, and 3 minutes later you have a baby, then it might take you, you know, 2 or 3 hours to get your legs under you. But if you're a typical first-time mom and you're 10 centimeters, so we're like, okay, we're going to turn off the epidural. In 30 minutes, we're going to push. Then we're going to push for 2 hours. And then you have this baby. Like, by the time you're ready to get up to the bathroom, your legs are totally under you. Like, it's not that frequent that I see it slow somebody down. So I wouldn't use that as a deterrent.
But it's good to know yourself too. Like, if you know that you're not good with anesthetic, if you know that you respond like really strongly or really strangely to anesthetic, I mean, that's good to know.
And I get very sick, like, even like going to the dentist, like, numbing, very sick.
Yeah, so that's good to know about yourself.
Super sick with my.
And so you might be able to say that, and they might dose it lighter.
While we're on, and I won't go into it a whole lot, but I actually have a research paper on the effect of epidurals in the second stage of labor. And just
so remember, the second stage is actually pushing the baby out.
Right. And so what they found is that women who got epidurals versus didn't get epidurals had no difference in their report of pain. And they, on average, first-time moms had faster deliveries without an epidural. So it's just something to think about. But like Megan said, it's a tool, right? Like, if you can't get the baby out, like, an epidural can help your muscles relax. So
I came into my first one like very close-minded, like I'm gonna have a baby without an epidural, and that's the only way I'm gonna do this. And I did it, and I pushed for 4 hours, and it wasn't that great. So then with the second one, I thought, all right, I did that. I can do anything. And then it was like 36 hours into an induction. I'm still 3 centimeters, you know, and the Pitocin is cranked up and we're not going anywhere. And so then it was like, okay, like, I don't know, you know, I've contracted every minute and a half for the last 36 hours. Like, how much longer are we going to do this? And so then I got the epidural, and an hour later it was complete and pushing, you know, so it's so different. And then the third one was induced also. And, you know, but that was only Cytotec. So that might be a difference with this delivery. Our doctors tend to use Cytotec to start inductions. And really, I think it's great because once you start Pitocin, you have to be on a monitor, and like you're a little more tied down. Like, you don't necessarily have to be in bed, but you do have to be on a monitor the whole time. And that's really hard. And Pitocin is really intense. And at least with Cytotec, you get a dose of Cytotec, and then you have to be in bed for an hour. But then you can be up, you know, we usually dose it every 3 or 4 hours. So then you can be up, you know, in the bathtub, walking around, doing whatever you want. And I just feel like it's a lot more manageable of an induction.
I do agree with what you said about, like, signing the papers ahead of time. Like, I remember when we came in, because I was like, oh, I'm not sure if I'm going to get it or not. And they're like, well, do you want to sign the papers? I was like, yeah, because I would rather sign the papers now.
Yeah.
And come in for my induction rather than wait until I'm like, I want it now.
Yeah.
And have to go through signing papers.
Yeah.
And all of that.
So I do tell moms when they come in, you know, for those of you that are kind of like on the fence, I don't know if I want it, I don't know if I don't, it's generally like 45 minutes from the time you say, I want an epidural until you have pain relief, right? Because I usually have to call in the CRNA. If you don't have an IV, I put in an IV. I bolus you a liter of IV fluid, and then the CRNA has to get there. If you haven't signed papers, they're not like horrible and nitpicky about it, but if you're like in excruciating pain and they're asking you what your allergies are, that's frustrating. And then by the time they set up and they do the epidural, like roughly 45 minutes. So if you're like, yeah, I want an epidural, don't wait until you're, you know, can't handle it anymore. Like, give us a tiny bit of warning. And I feel like, so I've had several friends that have been like, nope, I'm not going to get an epidural. And so they're doing really good. And Annika wrote rhythm up there, and that's so true. Like, they're in a rhythm and they're breathing, or they're in the bathtub, or they're on the yoga ball, or whatever they're doing. And then when they decide, like, okay, I'm going to get an epidural, your whole mindset changes. It really does. And rather than like dealing with that next contraction and just like going with it, I just remember one of my friends saying, where the fuck is Gabe? You know, and it was like, she had been just totally fine. Like, in the bathtub, we were doing it, life was good. And then when she decided, like, I'm going to get an epidural, like, her mindset changed so much. And it was just like, you know, I couldn't do anything right. Her husband couldn't do anything right. And Gabe couldn't get there fast enough. And so it's like, you know, your mindset does change a lot.
Gabe did tell me that if an epidural, like, if you don't want an epidural, it's not even an option. Like,
right.
Because if you go in with like, oh, I'm going to get one or not, then you're going to get one. So, because he's always asking me, and I'm like, I don't know, like, I prefer one too, but that's like, if you're on the fence, you're going to get one. So.
Yeah.
It is very much a mindset. It is a mindset.
And that's why.
100%, you can't, like, you have to go in, but you're and it's not even an option.
Yeah. Well, and I mean, hence, like, pushing for 4 hours, right? Like, pushing, like, anything past, like, 2 is, like, considered, like when I hear patients that have pushed for 2 hours, I'm like, oh my God, your pelvic floor, we have a lot of work to do. And so for 4 hours, you know, like, that's.
I remember the doctor at one point asking me while I was pushing, are you giving up hope? Like, what doctor says that? Like, nobody says that. And so I think that was, like, his way of, like, signing the informed consent for C-section. Like, this is probably not going to end well. And I was like, no. And he was like, oh, okay, then I guess we'll keep going. So, yeah, it is a lot of mindset. It really is. But you don't have to be, like, as stubborn as I was to be like, no, I'm not doing it.
Yeah, it is not giving up if you go in and you're like, no, it's not going to happen. And then you're stuck at 3 centimeters for 36 hours.
But
like,
for sure, your body can do this.
Right.
Like, it can. It is amazing.
I think if they're on for like the chocolate popsicle, like that's my, like.
That's the deciding
But I
factor.
really want that chocolate pop.
Like, if I can't have a snack and somebody tells me I can't have a snack, I'm gonna throw a fit, and then we're gonna get a bad.
Well, so,
Yeah.
so this is before we really enforced, we used to not be very good at enforcing clear liquids after an epidural. And so I had gone like 36 hours, I hadn't eaten anything. I got this epidural, I'm pain-free, and I was like, oh my God, get me a Subway sandwich. So Jason did, and I ate it all. And then an hour later, I needed to push, and that was a bad decision. I was like, now I'm going to have to throw this whole sandwich back up. That's not going to be very good. So do stick with clear liquids. It's easier to throw up.
All right, what about you guys? What works for you?
So I was like, short labor. Obviously, when I had Lily, they started my contraction at 7 in the morning, but I didn't really feel anything until like 2 in the afternoon after they broke my water. And I got my epidural at 6:15, and it rushed it. I was pushing at 6:30, it's just before I started on two. So I would prefer to obviously have that done again because it wasn't bad. I like to walk around. I sit on the yoga ball quite a bit between 2 and 6. I'm on 4 pain medicine. I rested. I slept most of the day, which was nice because of that. Epidurals all the way. And the vaginal. I don't want any forceps. I don't want to be cut. I don't want to be. But if it's looking like that, great. We can snip it. And we're having a growth.
Awesome. What about you guys?
I don't really want a long labor, but I don't want it to be super short. Don't use episiotomy, no forceps or vacuum. I would like to walk around during labor. I don't want pain meds or the epidural. Vaginal delivery, and we are having.
Okay, so I just want to say a couple things about the vacuum, right? So this is a vacuum.
You want to show the folks at home too?
Oh, yeah. Here's the vacuum, guys. So with the vacuum, again, it's a tool to achieve a vaginal delivery. I realize that most people don't want it. But like I say, I think when I've run the QI, about 25% of our first-time moms have a vacuum at delivery. So the chance that like 2 or 3 of you are going to have it is probably fairly likely. So what we do with the vacuum is it's not something that 5 minutes into pushing, the doctor's like, okay, you're a terrible pusher. Let's just go ahead and get this over with. That's not what we use it for. This is used in the case, if you've been pushing for 2 or 3 hours and you're exhausted and we still need to get that baby under that pubic bone. That's the hardest part, is getting that baby under that pubic bone. If you're still having a hard time with that and you've been pushing for a long time and you're exhausted, a vacuum is a great tool to help get that baby underneath that bone. So we have pretty strict guidelines when we're using it. Generally, we don't leave it on for more than 20 minutes. This is how we pump it up. So it just suctions right to the back of baby's head. And then the doctor just pumps it up with their hands. And so then it's just suction cupped to that baby's head. And the doctor just puts gentle traction on it. And that's how they're helping that baby's head come under that pubic bone. So if the vacuum pops off, that's we try to have less than 3 pop-offs or no more than 3 pop-offs per delivery. So you can imagine if it's if you have a baby with a big head and you're trying to get it under that pubic bone, and your soft tissue, your skin is really tight and we're having a hard time. And if the force of your skin is going to actually cause it to pop off, that is the instance that we're most likely going to cut an episiotomy, right? And so that's when they're going to cut from the bottom part of your vagina down towards your rectum to allow more space so that vacuum, as it comes through, has room without popping off that baby's head, right? Again, this is just a tool to have a vaginal delivery. It's pretty darn common. The doctors are pretty good about talking to you, especially Dr. Gallagher, ahead of time. Dr. Graham is pretty good about it too. Dr. Husby and Dr. Foster sometimes wait until, closer to the time that they're using it to tell you about it. But the greatest risk with it is an intracranial bleed. And the risk of that in just a normal vaginal delivery is like 1 in 1,200 deliveries. And the risk with a vacuum is 1 in 800. So it does increase the risk slightly, but it's probably still a lower risk procedure than a C-section. So that's why we choose to use it. Now, your cards say forceps or vacuum, and it's either or. So most of the doctors these days are trained on vacuums, not on forceps. So we do have forceps, but it's not like they'll try the vacuum, and if that doesn't work, they'll go to the forceps. Like I would say with quite a bit of certainty that they're going to go with a vacuum. I myself was a vacuum baby. My first 2 kids were a vacuum baby. Dr. Gallagher tells people that his first son was a vacuum baby. So it's really, I mean, it's pretty darn common. And like I say, it's a tool to achieve a vaginal delivery. Cutting an episiotomy is not something that we routinely do. You know, like a long time ago, they used to do that on every single person that delivered. And we don't do that anymore. But I would say the most common time that we cut an episiotomy is if we're using a vacuum and it's just that like your soft tissue is going to cause the vacuum to pop off, or that baby's head is having a hard time fitting through because of the soft tissue. They'll cut an episiotomy to make a little bit more room, if that makes sense.
And a comment about episiotomies too. I mean, like, it sounds horrific to like watch a doc come at you with scissors and like head straight through your vagina.
It's better to recover from.
Yeah, it is far better to recover from. So all the women I've worked with perineal injuries, like they don't even feel the episiotomy. Like even when I'm stretching the scar, they're like, "What are you working on right now?" So that perineal membrane, it's just connective tissue. It is where your pelvic floor muscles tie in. So like we're talking like right here, like that's where the incision will come down to. But it's just connective tissue with very little like sensory input. So the tears that people tend to feel the most are like anything that goes up, like people feel very significantly, or if something like tears farther. And that is one of the risks with episiotomy is like once they cut it, then it has the risk of tearing farther. But if they just cut the episiotomy, then again, most people don't feel it. I have something else to say. Oh, so one thing that you can do to really help avoid like that skin being really tight is you can actually stretch this area ahead of time. So there was a period of time where people felt like, oh, during labor, we'll get in there and we'll just like really help to like widen the vagina as the baby comes down. And they found that then women just had like really irritated pelvic floors that are being overstretched and then overstretched even more as baby comes through. So now what I recommend to folks is really about 36 weeks, you can start doing perineal massage. So it's a 2-person activity when you're 36 weeks pregnant. And so that's either something that like you can come see me for and I'll like teach you how to stretch, or I'll give you guys a handout today. And essentially what you do is you have 2 fingers in your vagina and you're going to pull like partners. You're going to pull, like if you picture, you're looking at the vagina like a clock, right? So like clitoris is at 12, rectum is at 6. You are going to pull like 5 and 8. And you're going to pull until like gals until you feel like you're like, oh, that's burning, and that's where you hold. And then when it doesn't feel as burning anymore, you pull a little farther. So I would say partners usually do one of 2 things. They go in and they like barely stretch. So like they're afraid of hurting you, so they like barely touch anything, or they're like, right? So find somewhere in the middle in terms of enthusiasm. But the thing is you picture it like stretching your hamstrings, right? So if you pull right now. So picture it like stretching your hamstrings, right? If you want to get better hamstring length, because you want to be able to touch the floor with your fingertips, like you would just hold that stretch for a while. So same concept, you're working on stretching those tissues. Most of the time, the resistance to pelvic floor stretch is actually tight muscles. So like doing like some prenatal yoga, like making sure you have nice, loose, open hips, working on some of these delivery positions that we'll talk through today, like those things are all great practice too. But that perineal stretching really provides a really, really good stretch at the muscle tendon, which is that's the connective tissue that is going to break if you tear. And again, you know, like if an episiotomy happens, it's not the end of the world. We will absolutely fix you back up. If you get an episiotomy and you tear farther, not the end of the world. We will fix you back up. But this is the direction you want to pull that stretch in. And I really strongly recommend starting to do that at 36 weeks because it makes a huge difference. And you only have to do it a couple of times a week. So if you need assistance with that, come see me for a visit, and I'll you guys can both come in and I'll show you how to do it. So. For the folks at home, do you guys want to share your birth plans with us?
I'm just gonna wing it like I did last time. I didn't have an epidural. I did a lot of walking, bathtub, did whatever it took, I guess, at that moment. So plan again. Awesome. So.
Great.
I don't really have a birth plan, but I do want to try vaginal, see how it goes.
Awesome. Sounds great. All right.
So now we will have you guys flip all your cards over and just look at what that delivery would be like.
So efficient. So how do you guys feel about these deliveries?
Wild to have a vacuum episiotomy C-section.
Like it all goes wrong.
Yeah, but that could all happen.
Right.
I feel like that happened last year.
But like that can happen, that you can have like an episiotomy and a vacuum delivery and it fails and you go to C-section. Like that'd be really shitty delivery.
And
It is, because I think she had the vacuum and I think pushed for a long time.
Yeah, you might be right.
And I think like doing this exercise emphasizes the point, you know, like we go on and we're like, I don't really have a birth plan, but you 100% have an idea of how you want this birth to go, right? Like, hell no, I don't want a C-section. Hell no, I don't want a episiotomy, vacuum, and a C-section, right? So, you know, again, like having that mindset of really and planning how you're going to get through this birth. So like if you hit that point and you're like, I don't know what to do next, or I don't know where to go next, or I don't think I can handle this anymore, like how are you going to handle that? Because these birth plans happen sometimes. And I'll tell you guys from my own experience, I totally wanted did I tell you guys this last time? I totally wanted the like women chanting and like waving and like, you know, incense and candles and like this home birth. And although my husband would never have gone for that, but that's like what I wanted, like supernatural. I was very committed. It was absolutely going to happen. And my birth was 7 weeks early, all of the interventions. I don't remember the first 36 hours after my son was born. And so things can change really, really rapidly. But, you know, I would say that birth trauma happens in all sorts of situations. You know, like we mentioned that sometimes people like aren't ready for the epidural to be turned off and to feel everything. Like that can be really traumatic. There's lots of women.
Or to have your mindset like,
yeah,
1,000%, I'm getting an epidural, that's what I want. And you come in and you get the epidural, and for whatever reason, it doesn't work very well.
Right.
And you still feel a lot of your labor. And I feel like that can be traumatizing to people,
Absolutely.
You know, to like, you know, or like my whole birth plan is like, I'm going to labor in the bathtub, and you get in the bathtub and it's horrid,
and
you know, and then you're like, now I don't know what to do, you know? So just like be open to different ideas.
And kind of how, like, play through these scenarios. Like, okay, so like we do wind up like in like more of an emergency section type of situation, or urgent C-section type of situation. What then? You know, like what do we want? And I have a really cool handout. I think it's on the back of one of these, but it's like making a cesarean delivery special. So we don't do like breech deliveries here, for instance. So those will wind up being planned cesareans. They call them elective cesareans, which I feel like is just like, I don't like that name. Like I didn't elect to have this, but baby apparently did. So maybe that's what they're going for. But you know, you can still make a cesarean delivery really special. And that was my experience on my second delivery. It was really incredible. It was a cesarean delivery, which wasn't what I wanted, but it was really, really cool. So So I'll make sure that you guys get that handout too. But yeah, I mean, like because you do have your bias of how you want this to go. And you don't necessarily need to, you know, like be doom and gloom and like, oh God, like, what if I end up with this birth plan that's right here? But, you know, just understand that sometimes these things happen. And that's our point in this class. It's not even necessarily to teach you how to labor or how to birth, although we try to give you some tips and tricks. A lot of it is, these are the interventions that could happen. This is why they would happen. And so it's, you know, if you're very committed to how you want to have this baby, then you go in with the mindset of, okay, we're going to do everything we can. And then if it still happens anyway, you know, you did everything you could. Yep.
So just super quickly about pain medications.
We talk a lot.
I know.
Yeah, that's right.
The different, you know, sometimes some of you on your cards said like, I do want pain medication or I don't. What exactly does that look like? So let's say you're that patient that comes in, you're 1 centimeter, you're contracting like every 7 minutes and it's 7 o'clock at night and you're just like, I don't think I can sleep like this. That might be a time when we give you like 1 dose of IM pain medication and we send you home for the night. You know, like it's maybe just enough to take the edge off. You can go home and sleep, you know, but there's not too much danger that you're going to deliver that baby tonight. We don't do that very often. So then the next option is IV medication. So that's kind of what Gabe was talking about with the fentanyl. So we also don't do that too often. So occasionally somebody won't want an epidural, but they'll just want like 1 dose of IV pain medication kind of to get them over the hump. And the IV pain medication that we use is like short acting, so it wears off pretty quickly, which is good because it does sedate baby a little bit. But for that reason, we really don't give it past like 7 or 8 centimeters. Probably if I'm your nurse, I'm probably not giving it to you past like 7 centimeters because I want that baby to come out and want to breathe. Like I don't want them to come out flaccid. So the thing that you kind of have to ask yourself, like sometimes in these classes, people will say, well, I don't want an epidural, I'm just going to get IV pain medication. But the thing to consider is like, if you're asking for IV pain medication at 3 or 4 or 5 centimeters, like how are you going to be handling labor when you're at 10 centimeters? And I'm not going to give you any pain medication when you're 7, 8, 9, 10 centimeters. So just kind of having that, you know, sometimes like, you know, we all have a meltdown at some point and maybe you just need 1 dose of pain medication to like help you like just have a break for 1 contraction so that you can kind of get your mindset going again. And that would be okay. But if your plan is like, I don't want an epidural and I'm going to do it all with IV pain medication, like that's not a good plan because you're not going to have anything in the toughest part of delivery. And then the epidural, like Gabe was talking about, is the most common thing that we're doing. Like very insignificant effects to baby. They do really quite well. You know, I think like right around 55% of our moms are getting an epidural. So it seems like when I'm laboring people, I don't know, like when I'm laboring people, I feel like there's a lot of people that have an epidural, but when I actually run the data, it's about 50-50, but I think that's because a lot of the moms that don't get an epidural, like, are the ones that, you know, the lacy part is that like fly in the door and shoot out a kid. You know, like they're not here as long. The ones that are here for 36 hours, you know, get an epidural more commonly. So that's kind of the different methods of pain management. We talked a little bit about that. So comfort measures. One part of this is, you know, we talked a little bit about like being in the tub, hydrotherapy. You saw in the video, like they were using like do we have a sprayer? I don't remember in our sprayer. Yeah. So like running water over the back, using the jets. Any labor and delivery, like our labor technique book you read is going to have something about relaxation and visualization and focal points, right? So something to focus on. And I put this rhythm, repetition, and ritual. That's from Penny Simpkin. She's like one of the original modern midwives, nurse midwives. And she calls them the 3 R's. So you saw it like in Brandy's birth, she had that rhythm where she was just like it was almost like a metronome going in her head. She was constantly rocking like that. And then the repetition. So sometimes that's something you say, sometimes that can be a movement you make.
I was taking a class and we were talking about women laboring through it, and one woman, she would like bang the table and say, I can do it, I can do it, I can do it. And like for hours, like that's what she was saying. And that's what helped maintain that focus for her. And then the ritual, right? So part of this is setting up your labor and delivery room. So whether that's like, you know, like fake candles that are like flickering, and so it's this really low light, whether it's a diffuser, whether it's like your blanket and your pillows, whatever it is, like it's that ritual that you set up. And then massage. So we'll talk about some of the massage positions while we talk, or some of the massage techniques while we talk about labor and delivery as well, or labor and delivery positions. So you can go and flip to the next one. So go ahead and take one of these and pass them on. So this is the cheat sheet that I was telling you guys about for partners. So all of these positions are what I am recommending to you in terms of like early parts of labor versus late. So what we think of in the difference between early and late labor is in early labor, baby is coming down through the top of the pelvis. So we call it the pelvis inlet. So you can picture that this top round part through here, that's what widens to get baby in, right? So we want this top part to open up. And then as baby exits, we want the pelvic outlet, or this bottom part, which is between your sit bones, your tailbone, and your pubic symphysis. That's what we want that outlet to open. So all of these positions are recommended based on that inlet outlet. So go ahead and grab your partner or a partner, and let's talk through some of these positions. So find a spot to stand up. Do you want to find her? No. This is really fun when Megan and I demonstrate this, and we're both pregnant, so you guys are going to have a lot of fun with it. Or do you guys, one of you guys want to demonstrate with us? Here, one of you pregnant gals, come up here. You can demonstrate with me. And then, yeah, the other can go with Megan. So if you're thinking early labor, so we're moving down into the top of the pelvis. So you want positions that help to open this out. So if you look at that first little like large box, it says low back forward flexion. So that is in like butt tucked and kind of rounded, this type of position, knees together and heels together. Okay, so this is like the extreme. So legs more together and heels more together. So like your toes are pointed out and you're rounded. Side to side movement is going to help open you up that direction. Pelvic rocking, so rocking like forwards and backwards, rocking side to side if you like to labor on a ball. And then low pelvic pressure. So Courtney, come on up here. So what low pelvic pressure is down on the hips. Come up here. You basically got it. MIP. So that's right. So low pelvic pressure is going to be, so go ahead and have your partner face away from you. Have your pregnant partner face away from you. Okay, and so if you put your hands on like their natural waist, that is, if you're looking for what used to be their waist, where the waist was. So where your hands are right now is up here on top. So this is where you're at on the pelvis. So where you're going to go for a low pelvis to help open up that outlet is like the widest part of, like below the widest part of the hips, right? You're basically on legs. And then what you're going to do, guys, is you're going to press. As hard as you can. So how long does the average contraction last? About 60 seconds, right? So I'm going to time us. Okay, so everybody assume the position on your partner. All right, so we're going to do low pressure. All right, so put your hands in that low pressure position right here and start pushing in 3, 2, 1. So push as hard as you can. Right? You're going to do it, Josh? Yeah. So I was living lower, Larry. It hurt lower. Did it hurt? Okay.
See, sometimes I think it hurts too, but
it didn't feel good. So keep pushing, keep pushing, keep pushing. That is only 25 seconds. If you let go, you were only halfway through the contraction. Never change your touch in the middle of the contraction, people. No. Keep going. I'm going.
Everyone when she stops.
Keep going. You got 20 seconds left. 10 seconds left. Here you go.
You've been training for this, Casey. Come on.
My arms are cold.
3, 2, 1. Finally, contraction phase. Wait, right? It is no joke, right? So a couple of things you can think about. If she's in the bed, now you're just pushing on one side, right? So if she's got an epidural and you're still working on that pelvic inlet, right? She's only 4 to 5 centimeters. You can have her lay on her side and then push that. So now let's everybody, so take a look at this early labor, right? So we have some fun positions for early labor. So let me show you one that is probably the hardest to look at. Let me steal this real quick. So the one that's called the dangler. So what you're gonna do, partner, so in that one, for instance, what you're gonna do is have your partner stand between your legs and then go ahead and sit down your arms. I didn't do that. So come down to like your armpit. There you go. Right, so this is something that can be like on the bed. Right? So now if you're thinking pelvic inlet, right? So you can put your heels together and let your knees fall out. That would be like a pelvic inlet, right? There is nothing modest about labor and delivery, folks. Right? Yeah. No, you're predictable. So let's say this is a position she really likes, and then she's ready to change. So to get her up, right? Because it's very important that you guys take her back. You're gonna hook under her arms like this. Bring your elbows down, and then stand her up like that. Good. So everybody.
You in the morning when I get out of bed.
So everybody take about 30 seconds and pick one of these positions and go ahead and try it, right? So you're thinking toes pointed outward, legs a little more together. You can add some low pressure. Go ahead and pick one and just try it.
How about the lap squat?
The last.
I can't help you guys after that one.
Wait, Megan and I will demonstrate, or Marty and I can demonstrate that one.
The lap squat, is that the one we're referring to? You'll be able to get her off. Yeah, when I was like 40 weeks pregnant and Annika was 32 weeks pregnant, she made us do that together in class, and like we almost never made it out of the chair. Like we're not doing that ever again.
Yep, and so then now you can even play with position, like go toes out a little bit more. Right, so again, like find these positions and then that rocking back and forth. Like there's something with rocking that helps your pelvis just move a little bit.
The support.
He's like, good. So are you guys doing the sideline?
Yeah, you guys got it.
I didn't need it.
So are you in the bottom? Yeah, okay, so now what you can do,
Or in the bath.
so picture early labor, late labor, right? So this is more like late labor.
Or you don't want your spouse in there. To me, if I was doing my period, if I was to do that, I would fart.
Right there.
Like in that position, I just do that.
Yeah.
Like,
Another
I don't know what it is, but like, I was crawling on the floor the other day and I sounded like a freaking airplane going off. I'm like, so I can't do stuff like that. And then having Keith behind me, poor thing's gonna get blown into the back wall.
All right, so now let's talk late labor. Okay, so now we're thinking that pelvic outlet. Okay, so you're trying to push the baby out through the bottom of your pelvis. So we are thinking things like your back is extended, right? So now you're like more in like the standard pregnant lady pose, like spreading your sit bones, knees apart and heels apart, right? Like, you guys ever seen a cow give birth?
Yeah.
Right?
Oh yeah.
Standard. Yeah. Pelvic rocking again. So like you're trying to like work that baby out through, and then higher pelvic pressure now. So now, Courtney, come over here. So now what you're thinking is you come back to like where that natural waist is, and that's where your push is. Yeah, so go heels out, Katie. So turn your feet so your heels out. Yep, so your toes are pointed in like your pigeon toes. Good. Yep.
So
And
the
then
early labor positions, like legs together, heels together, that to me, like, does not feel natural at all in labor.
yeah.
But it's this spread apart, swaying,
Yeah.
squatting, that feels totally natural, like that will come to you.
And you can even think too, yeah, because legs together might not feel right, but what you can think about too is even just playing with hip position. So even if you've got feet pretty wide apart, toes out is going to change the orientation of your hip muscles and the way your SI joint does versus heels out. Can you guys feel that difference when you just change that heel position? So, yeah, totally. So let me show you the lap squat one. So, because this is a fun one, but not everybody likes it actually. So this one, partners, you're going to sit not in a rocking chair like this. So make sure you sit on the edge of these, and your partner is going to sit on your lap facing you. You want to do it? I might be. Right? So your partner gets on top of your lap, and you're going to get them pretty close. Good. And then, yep, so then you just spread your legs, and you hold them. I love this. This is the one-on-one.
Somebody film Courtney.
I feel like this is how I got here. So something you can think about is like drop, because what's nice here is you get like a good sit bone spread with this. So during a contraction and then relax in between, right? Or maybe vice versa. And all you have to do is move your legs in, right? So like go back out, like come back in. All right, and then easy, that's a good option. Easy for you. All right, you guys can go ahead. You can try the last one if you want. Go ahead and try one of the late labor positions, and then think about that. Think about that toes in, toes out, back extended. So like another great labor position might be like I'll get that for you guys. So like on top of, a ball or the chair, and now you have like hips, like feet again out, right? And letting your back sink. One is you look like a help me. So the Captain Morgan position, if you guys are looking at that one, the ones like this, a girlfriend of mine has delivered like all 3 of her kids in this position. Like she just like parks herself here, and this is where she labors. And what's nice is you get like some pelvic twist. So even if you like switch sides, you can play with like hip internal and external rotation. You can play with your back position. So again, we're talking about like millimeters of space. So anything you can do to get like an extra millimeter of space is going to help baby drop down. So quickly, let's go through some pain management techniques. So if you flip over to the back, right? Okay, so before I do that, let's talk about how to use this. So you're in early labor, dads or labor partners, and you try this one. She hates it. You move to the next one. She kind of likes that one. So you hang out there for a while, and then she's like, we need something else. And you go to the next one, right? And you just, like you said, you work through. And if you don't feel like you're being super effective, if you remember nothing else, remember these positioning ideas, right? So toes pointed out, toes pointed in, rounded back, extended back. Like if you can remember those different things, that'll help you get through these different parts of labor. So then if she's getting to a point, she's like made up her mind, she doesn't want an epidural, but she's really starting to struggle, starting to lose the control. On the back side, these pain management techniques can be really helpful. So you can get a sacral counter pressure. So your sacrum is the bottom part of your spine that's in your pelvis. So again, you find that natural waist, you come to the middle and you drop straight down, like right at the butt crack. That is like you're right in the middle of the sacrum then. And you can do counter pressure on the sacrum. So I helped labor a patient of mine a couple of months ago, and I gave her counter pressure the entire freaking time for like 2 hours. And so same thing, she was early labor, so we talked early, like we were low and forcing like that rounded back position, early labor, and then as she got later, I moved my hand up and forcing that more extended back position, right? So that's, when we talk like rounded and extended, this is the bone we're talking about, is we want initially your sacrum to turn this way, you want your sacrum to tuck, and then you want your sacrum to extend. Does that make sense? So when you're thinking sacral counter pressure, I mean, she may know too, and she may want the opposite of that, and that's fine. Be like, that physical therapist doesn't know what she's talking about. That's fine. Do whatever she needs. But if you're not quite sure what to do, these are good places to start. So that sacral counter pressure, you can do that double hip squeeze that we did, right? So you can go high or low depending on where you're at in labor. Also doing the double knee press. So she just sits in a chair with a back, probably, and you just push straight through her femurs. That's a really easy one to hold because she's solid and you can just lean your whole body weight into her. Our labor and delivery beds go up into a chair position. So this is a great position for epidural, like if it's still a lot of pressure, that's a great way to just like give a little stretch to the pelvic floor and give a little pelvic relief. There's some of these techniques for belly lifting. So everybody go ahead. Gosh, we're going way over. Thank you guys for letting us use some of your time. So go ahead and grab your partner again. And here we go. Can I borrow your reference sheet actually? After Melanie, can I demonstrate me? And then Larry can take over. So belly lifting. So you're going to take the hot dog style, right? So the long sheet, and you're going to wrap it around belly. So this is great, especially if you have a lot of pelvic pressure. He's like, don't pull down anywhere. Right, so you can get it around the belly, and then turn it side by. Yep. There you go. Yeah, I would go hamburger across. Yes, with a wide end. And once you get that, you're going to twist the back until it's like pretty tight. And then you can lift right here. Right, so that's going to help unload quite a bit. If you have a long enough blanket, you can even hand the ends to mom, and mom can hold the ends and give herself a little relief there. Okay?
I actually saw somebody online took like a Moby wrap, you know, like the inner wrap, and like put a Moby wrap around their belly just to like, you know, because like after you've been packing your big old fat belly around for 9 months, like your back and everything just gets sore.
Yeah, great idea.
And just to wrap it and hold it up was really nice.
Yes, absolutely. And then, okay, so this is a nice belly lift, especially for pelvic pressure. I also like it because you're kind of tipping baby back into your pelvis too, right? So you're kind of promoting that position. The next one, Larry, you can come on up for this one. So the next one is it's the butt shimmy. So Maddie, I'm going to have you like this on the table. Okay, and then what you're going to do is drape it across her butt, and then again, like give yourself handholds by twisting, and then you're going to shimmy. So the shimmy is hard, right? So the shimmy is kind of hard. So I definitely try this because this may be really helpful. Yeah, so picture like a plate of Jell-O, right? So it's not like big, wide, shape. Like, you're gonna feel like that. But again, like fractions of millimeters, right? Like that's what we're trying to get out of this is fractions of millimeters. So and then you can see from the pictures, you can have her. Yeah. So you can grab it underhand. Yeah. There you go. Okay. And now up it like you're milking a cow. Yeah. Sorry. There you go.
Yeah, that's good too.
Right. So again, then you're thinking about holding that for 60 seconds during that contraction, right? So you can do this a couple of different ways. You'll see on the picture, like she can be like in hands and knees or kind of in a child's pose. You can have it under the belly again, and then you like stand up behind him and shimmy this way.
So yeah, show them Rebozo 50.
Okay. Who wants to demo that hasn't demo? Study? You look like a good demo. You're all pro at this now. So for Rebozo sifting, this is a great thing to do too, just to optimize baby's position. So hands and knees is the easiest position for it. Okay, and then partner, what you're gonna do, so for this one, you're actually gonna be under the belly. So you'll go under the belly, so you're more on the hips, and then you're sifting, right? So you're sifting the pelvis here.
Does it fit?
Yeah. Yeah. So go ahead and get that.
That's so good. I think
Gary's like throwing me on the ground. Go ahead and go on your back. So then you can then I probably need a break. So then the next contraction comes on, okay, here we are, right? So, but this is another great way, again, just to help get that fraction of a millimeter. So another pain management technique, if you're really just trying to like get in the right headspace, so is actually a head wrap. So you take vision out of it, sorry, and then what you do is
If you suffocate them and they pass out,
they will also not feel anything. So you just twist until they feel like it's tight enough, and it's just something about that pressure that some people really like. So, and then that's something they can hold too. So, you know, like some people like to massage, they rub on the back, that might be something that they like they just helps them get in the right headspace. So those are pain management techniques. I mean, honestly, practice them, and partners especially, like, you cannot be sifting for 4 hours with your back like this, right? So you're going to be like in a lifting stance, sifting this way. Yeah, this is an athletic endeavor for everybody.
close to north every day. They're tired of looking at the stats, but we're not my favorite.
Questions about any of those, you guys? We have all, I mean, we're a hospital, so we have all sorts of sheets. So if you want to try one of these, like, just holler, like, right at the beginning, and we'll make sure you have a sheet. If I come in on your labor, or you guys want me to come in on your labor, and I'm able to drop by, these will be some of the things that I recommend. Like, hey, have you guys tried this position? Have you tried sifting? Have you tried, you know, all of these different pieces? So, yeah. So, dads, this is I like highly recommend these sheets for you to be able to know, like, what to do next. So, cool.
Okay, really quick, we're just gonna go to labor and delivery and take a tour if you guys want to, and then you can go home after that. So take your stuff if you want to, or you can come back. Are you gonna take this or what?
That's probably the easiest. What do you think? Yeah. I'm gonna skip the tour. Okay. You want some fruit for the road? I do. Okay, we'll take a big chunk of it.
I have Greek yogurt.
And we're coming back in here, or if you want to come back in here, that's fine, you guys too. Just Megan and I'll come back. You've been there a few times?
I'm so excited. I went to a lot of training, 2 days work.
One thing we mentioned, or did we mention that you have to come in through ER if you guys come in after hours? So if you are not coming in Monday through Friday, 8 to 5, then you'll power 8 to 6? 7 to 5. 7 to 5. Then you'll come in through the ER doors, and you have to buzz in.
I don't know, the other time.
Yeah. And sometimes people come in here, but if the doors aren't locked or are locked, don't panic. Just come in through the ER. Hi, Teddy. Bye, Teddy.
And then after it's all So if it is, so the nursery station, and then our labor and delivery unit is a long unit. So you have to push the little silver button to get in and out every single time you come in and out, and that's just for infant security. So once we come through, this is our nursery. We don't typically keep our babies in here. It's more of just like a storage room for all of our infant things.
If you do have a baby that's sick or requiring a little bit of assistance, you might bring them in here for a little bit. But typically our babies aren't in here. You know, that being said, if you do have like a really fussy baby and maybe mom's trying to get a little bit of sleep, we don't mind if dad brings the baby in here and rocks them for a little bit. But typically our babies are in the room with you 24 hours a day. Okay. So this is our little nurse's station right here. So if you are laboring, actually in labor, there will most likely be somebody right back here. If you've already delivered, sometimes our nurses have to take care of patients out on the floor also, so they might be just bouncing back and forth. We have ice and water machine here. We'll usually put a coffee pot up here if you guys are coffee drinkers. Just ask for coffee if you want it, and help yourself to that. These are the double doors that go back to the OR. So if you did have to have a cesarean section, straight through those doors to the OR, so it's a pretty quick trip. These are our labor rooms. So we have 2 rooms set up just like this, which are like mirror images of each other. So they're pretty big rooms. The bench under the windows, partners can sleep on that if you want. Dr. Gallagher says it's the man killer, the worst bed he's ever slept on. So we do also have rollaway cots. So don't be afraid to ask for the cot, and we'll usually put it in here. We also have rocking chairs, but they're not always in every labor room. So if you want a rocking chair, just ask for one. We're happy to get it for you. These are our labor beds. So the bottom third of the bed breaks down. Like Annika said, they can be shaped like a chair. Lots of different positions.
We have squat bars if you want to squat.
Yep. IV pool. So, I mean, you will have at least like an IV in your arm, but you won't necessarily be hooked up to a pump driving that around. But if you are, it's here. This is our fetal heart monitor so that we can monitor baby. But we also have a telemetry unit. So if you did end up on Pitocin, we do have a little monitor that hooks on and you can walk around while you're still monitoring baby, which is nice. This is just in case we have to help baby breathe right after they're born. So just because this warmer is in the room, like don't panic and think that we think something's wrong with your baby. We just have one of these in every room. So that way if they do need help getting started, we can help them. And it's also nice because if you're the mom and your baby is right here, like even if we're having to assist them with breathing, it's not like we're taking them to another room to do it. Like they're right here next to you. So I think as a mom, that's like comforting to at least be able to see what's going on. But typically, all of our babies, as long as they're doing well, go skin to skin right at delivery and stay on your chest for at least the first couple hours. So you can expect that. Here's the jacuzzi tub. You guys can size it up and see if it's a 2-person tub or a 1-person tub.
Couple, maybe dependent.
Four. Hopefully it's 3 to 4. 3 to 4. Okay.
That's a 6-person jacuzzi.
It does have the jet, which is really nice.
I need to come here on like my lunch break.
Yeah. So like we said in one of the earlier classes, just make this your nest, like build your nest. So bring your own blankets, your own pillows, your pajamas, your slippers, your music, your essential oils, like whatever you want to bring, whatever makes this like a comfortable place for you, just bring that and make this your nest, make this the place that you want to meet your baby.
These rooms are also really sunny, which is great. Our windows are like only one way. So you don't have to worry about like, PTs out there like walking one of our inpatients in the courtyard, like they cannot see you. So
one of my friends, was like hands and knees on the bed, completely naked, delivering, not a care in the world that the window was wide open. The next day she goes to breastfeed, and she's like all covered up and she's like, do you think we should close that shade? And her husband was like, are you kidding me? Like you delivered on this bed naked yesterday and the guy was right outside the window trimming the bushes. But you don't have to worry about it because it is business, so they can't see it.
However, the rooms over in acute are not tinted. So heaven forbid if you have to like go home, or if it's really busy, if you all deliver at one time and it's really busy and somebody has to go out there, those windows are not tinted. Okay, so on out the hallway. This is where we typically put our mamas that have a C-section. It has 2 beds. If you have a C-section, you're typically here for like 2 to 3 days. And then there's not a bathtub. There's just a walk-in shower. I haven't had a C-section, but all the moms tell me stepping into a bathtub is not easy after you've had a C-section. So it's just typically where we put our C-sections. But like I say, if it's really busy when we deliver, there's always a chance that we might put you in a room out the hallway.
And sometimes people recover in here too, like we don't have a C-section coming in, but and there's 2 people in there, like we'll show up this room before the acute.
Yeah, it's like I say, we typically keep this for C-sections, but you know, there's a full moon and everybody delivers the same weekend, and then we just do whatever we have to. Okay.
Any other questions? Gosh, that's about it.
Almost 3 hours of it.
Yeah. All right, well, if you guys don't have any other questions, that's it for us. Thank you.